Hi, and welcome back. This is season 3. Very exciting. We've got 2 seasons in of the State of Healthcare podcast. This season, we're actually delving into what I consider the conditions nobody talks about. So if you haven't heard a lot of we never really researched or studied the female body, yes, we are definitely delving into that. That is a hot topic. Women's healthcare has been pushed aside for far, far too long. But we're not just going to touch on that. We haven't forgotten about the men in the world either. But we're going to be hitting topics that people like to steer away from. And I'm excited to hear that there's actually a lot more going on in these areas. But knowledge is power. So again, like in everything that we talk about, you need to fight for your healthcare. Knowledge is power. So you're going to hear about conditions and maybe things that you might have had symptoms on and you've been afraid to ask about. So that's what we're going to be exploring. So welcome to season 3. Yes, we have not really studied the female body, but we're going to be hearing about a bunch of things. So come along with us on this journey. Hi, and welcome back to yet another episode of the State of Healthcare podcast. We are really exploring a lot in season 3. This is kind of a women's healthcare focused season, right? We've never really studied the female body. It's trying to like capitalize on that. But today I have Sarah with me, and I'm going to let her introduce herself in just a second. But we're going to be exploring a few issues. We've also introduced a little bit of men's health into this because we aren't ignoring them. But we're going to kind of explore some other issues along this. And this season we talked about that we're going to talk about things that maybe we're not as comfortable talking about, but we should be, because people shouldn't be suffering in silence. So I'm going to let Sarah introduce herself and talk about your background.
Hello, I'm Dr. Sarah Brinkman. I'm a physical therapist. I am originally from Chicago, Illinois. Did some schooling of my undergrad at University of Minnesota. Got very burnt out from the snow and came down here for physical therapy school. Yes. And I've always known I wanted to go into pelvic health, whether it was women, gender affirming care, men, from a very early start into my career.
Okay.
And it kind of just progressed from there.
What made you choose that area?
Yeah. Before I started physical therapy school, I actually worked at a PT clinic in Minnesota.
Okay.
And they had everything. I mean, at its core, it was a general orthopedic clinic.
Okay.
But they had visceral manipulation. We had a patient who had undergone cancer treatment, and they treated a lot of cancer patients.
Okay.
Going through either remission or currently in treatment. And I was lucky we had 4 pelvic health PTs through the span of we had 3 clinics. So it was a large part of our patient population.
Right.
And when I was working there, I worked at the front desk. And as one does, when you're trying to avoid work, you just kind of talk with the patients at the front. And I fell in love with our pelvic health patients.
Okay.
For one, it was an area where I was not very aware of even existed.
Right.
And I talked to them often how they didn't know it was an area that existed. And just coming somewhere where they felt like someone was finally hearing about their conditions, they were getting help, they felt very empowered, and it just really excited me to talk to them and to see their progress through relatively easy interventions.
Right.
So I think overall, the patients are what really drew me in, and the mentors I met along the way of being with other pelvic health PTs. There were a variety of ages, and they were all fantastic and really progressive, strong women. So I was like, I want to be that. That's great.
No, that's amazing, because I feel like when I was in PT school, which was a while ago,
No.
she's very kind to me today, but there was like, we had one lady who came and talked, and half of her practice was vestibular and half was pelvic floor.
Yeah.
And I feel like now you could just fill it with pelvic floor, but I
Totally.
also am glad that there's been more like education and awareness and things like that. So
Yes.
I'm excited that you had strong mentors.
Yes.
And it's also interesting for the patient side that, like, you know, that at least they were in there, but like probably I'm assuming a wide variety. Like, I don't know,
Totally.
maybe, and again, I asked this everybody, like general conditions, what are the complaints you're seeing?
Yeah. I think the current area that I'm in is a lot of postpartum care. That's kind of our clinic, is maternal, either while they're pregnant or postpartum. That's our niche, and that's the main population we see. But because we're a pelvic health clinic, we see all the other peripheral ones of, you know, pain with intercourse, vaginismus, all the other kind of chronic pain conditions.
Okay.
We don't treat men as much, but common ones that are out there like prostatitis.
Okay.
And Erectile dysfunction is actually something that we could treat too.
Okay. So in case you're wondering, we did have a little bit on men's, but that can be treated also, pelvic floor physical therapy.
Yeah. So our clinic currently is like a postpartum lens. Before PT school, I kind of saw the gambit of everything. So I'm aware of a lot that's out there.
Okay.
And I think that kind of pushed me to, okay, I love my postpartum women. I love helping women get the treatment that they need. But there's a lot other out there that I like to look at too.
Right. No, and I do also think that a lot, I know the cat will probably join us at some point in here, but a lot of people just think of pelvic floor. Well, sometimes I think we've been talking about how women after pregnancy just think they have to put up with this crap.
Totally.
And so I'm glad that they're getting more care, right? But a lot of people think I shouldn't go for pelvic floor issues. I haven't had a child. I haven't done this or that. I haven't.
Yeah.
So I'm glad that you're also like branching into the other areas.
Everyone's got a pelvic floor, so we can treat it. Yes.
Right. And so from there, I was just curious. You had mentioned another diagnosis after pain. It was
vaginismus.
Yes.
Yes.
I was like, I don't think I'll say it right. So what is that?
Yeah. Vaginismus is a condition where at its base, it's basically a tense pelvic floor.
Okay.
But what it is where the vaginal wall, so I'm going to talk about more of like women's health here.
Right.
So the vaginal wall and the muscles surrounding the pelvic floor are very, very tense, and it can't tolerate penetration. And that can be in the scope of they can't tolerate a speculum for OB-GYN care, or they can't have penetrative intercourse.
Okay.
So what vaginismus does, or even like tolerate a tampon insertion. So it could be very tight. What the treatment is relatively simple. It's dilators. I don't know if you've talked about dilators on here.
Okay.
So dilators are a set of varying sizes that are insertional tools. That, I mean, they can start as small as my pinky finger. Just to get people to start tolerating touch and sensation down there. And what they are is you lubricate the tool, insert vaginally, and you just get used to that sensation, and you slowly, progressively get bigger over treatment. And to kind of relate it to gender affirming care, dilators are a huge tool that we use when people have vaginoplasties, which is where someone transitions from a man to a woman. The cat is loving
I
you.
know. My cat's like, I'm going to come in the middle and I'm going to attack your hair while you're trying to be serious. So we'll ignore. Back to gender affirming care.
Yes, yeah. So dilators are an excellent tool that you don't just need vaginismus or to have had a surgery. Could go through the whole list of, you know, if they can't tolerate a speculum again, or if any sort of intercourse is painful, or if they just can't afford physical therapy and they need something and a plan to, okay, let me do this and come in and troubleshoot everything.
Oh, wow. Okay.
So they're a wonderful tool.
Right. Yeah, I don't think we've gotten to actually talk about the tools of what goes into it. We've started with just trying to break the barrier of people even talking about it.
Got it.
And then being like, what do we do? And why pelvic floor isn't just a bunch of Kegels, right?
Yeah, totally. Yeah.
Because everyone's like, do you teach Kegels? Is that what we're doing? And I'm like, not everybody needs those.
No, they've got their place. Yeah, certainly.
I'm not downplaying that
No.
in any way, shape, or form. Really important. But
yes.
So the reason we brought you also in is that one of those other areas that you started working on is gender affirming care.
Yes.
And again, we also had a little bit of conversation that this can lead to a little bit of politically charged conversation.
Yes.
But what we are trying to do is, as a physical therapist, so I'm going to give you the disclaimer before we launch in and ask all the questions. My job is not to judge you for what you do. My job is to be like, what do you do? When do I need to get you back to whatever? So whatever your thoughts on this is a population that does need physical therapy. So
truly, yeah.
And we don't want that to be ignored. So talk me how you got into that area.
Totally. So I think I've always been someone who's been drawn to areas that don't have a lot of support in them. And I think if I'm being honest with myself, that's probably why I like women's health initially before school, is I saw women and men, I should say pelvic health, saw these people who were going, I mean, sometimes 10 years without getting the treatment that they need. And I'm very much someone who thinks PT is like, the interventions are pretty simple, right? Like what we're doing can be very easily implemented into life. So I noticed that I just got very excited and very empowered when I would think about certain groups of people.
Right.
And I'm always someone who's moved through queer spaces,
Uh-huh.
even from a young age. I remember in high school, I would go to pride parades. My
Mhm.
friends and family have different kind of views and different sexual preferences. So it's
Right.
not a new area for me. It's
Right.
somewhere I feel very comfortable.
Right.
And it was actually in physical therapy school
Mhm.
where our director is lesbian and she was giving a talk on different LGBTQI spaces and
Okay.
how to be a good provider in those spaces.
Uh-huh.
And maybe this is something I shouldn't say, but while I was in the lecture, I'm like, this is a little boring. Everybody knows this, right? Like, why are we even spending the time talking about it?
Not realizing not everybody knows this.
Totally. And then my classmates start asking questions, and they were great questions. It wasn't anything that was judgmental. They were just trying to understand more and they were trying to really get into the space.
Right.
And a little light bulb went off in my head of, oh,
Not
not
everybody knows this.
truly. I mean, I'm lucky that I live with people and I'm in a space where everyone's
Mhm.
accepted, but
Right.
that's not the case.
Yes.
So going through that class, I was like, okay, well, this stuff is obvious to me.
Uh-huh.
I love working with people who are queer in different kind of spaces. I can be that safe space. I can
Right.
definitely open it up. I'm someone who is very advocacy forward.
Right.
So it excited me to think about, oh, let me create this little sphere and just start
Uh-huh.
talking to people that these are issues that are happening. These are issues that we should treat. And I do think sometimes people who are in gender affirming care don't get that outward vocal, I treat you, I like working with you, like this is somewhere that you should be.
Right.
And we'll talk about different interventions for gender affirming care,
Perfect.
but they're really similar to what's already going on in pelvic health.
Okay.
So I didn't need a lot of extra education on what I was
Uh-huh.
already certified in because everyone has a pelvic floor.
Right.
Everyone has similar treatments. They're
Uh-huh.
muscles like anything else. So when I'm saying like I work in gender affirming care, it's really just so I can create that safe space for people to be like, I like working with you. I want you to feel safe with me.
Right. No, and I think that's important because when we talk about like so women's healthcare, right, has already been kind of marginalized, right?
Totally.
And again, whatever your thoughts on the things, a lot of times women get brushed aside. We're usually told it's our hormones, we're hysterical, we're whatever, right? So we're already up in this little tiny population
Yes.
of like having to fight to even just get taken seriously going to the doctor. I assume it's more like 100 times if you're in a gender affirming,
Truly.
especially in a transition. Like not only is there like the political views and maybe having to battle against that, but to have a safe space because again, it's a different thing. But we talked a little bit like I love to specialize in aerialists and like dancers and burlesque and whatever you're doing because I feel like that population gets go they go to the doctor. The doctor's like, stop doing these crazy things that you're doing
Yes.
where I'm like, no, you can still do these crazy things, but like,
They're
let's make some
athletes.
change.
Yeah.
Like this is a sport. Like,
Right.
treat it like a sport, and
They
let's
get
do the
injuries.
things. Yeah.
Totally.
So, so for my question then with that, what are the special issues that you do have to confront in that area?
Yeah. I think there's kind of two areas that immediately jump to my mind.
Okay.
Is the physical issues and
Uh-huh.
then the mental issues that come along with it.
Mhm.
So physical issues that are very common that I see, I want to first say they're again very similar to what I'm already seeing in like postpartum women and women's health. Tight pelvic floors, weak pelvic floors, trouble with incontinence, trouble with, having penetrative intercourse. It's all,
Right.
if I were to just say symptoms, you could probably relate it to any gender,
Right.
really.
Uh-huh.
In that aspect, the physical body isn't much different.
Right.
I will say there are 3 big surgeries that are out there. So there's a vaginoplasty, which I mentioned earlier, where a man is transitioning to a woman.
Right.
There is a phalloplasty, where a woman is transitioning to a man. So knowing what the surgery is and how that impacts the body,
Okay.
it was the main difference there. And then there's top surgery, which you can kind of think, I almost feel like people who are in like breast cancer care are like super suited for that kind of work.
Right.
But just knowing what those surgeries are and how they impact the body are very important. Similar if we knew, how does a bladder sling impact the body? How does having a hysterectomy impact the body? So physically, there's a few differences there.
Okay.
But I think the main hurdle that I see is actually like mental health that comes up. A lot of people are dismissed. A lot of people face providers that have biases, although we're not supposed to.
Right.
And then we also just have the fact of them they're fighting feeling comfortable in a body
that's new, but
that's
maybe that's
new.
where they wanted to, like, knew they wanted to be.
Exactly. And sometimes they don't have the access to those surgeries. So then maybe they are in a body that they don't like how it operates.
Right.
But we have to treat it for the dysfunction that they're feeling.
Okay.
So, and I'm obviously not a mental health practitioner, but just being in the PT world,
yes,
we spend a lot of time with patients. We can really dig into the issues that are plaguing them. So I do talk to them a lot about and refer out as needed, of course.
Right.
But I think overall, again, want to say it's very similar stuff to what I'm dealing with postpartum. There's a huge mental aspect of postpartum care. We actually just had a therapist talk to our clinic about screening for postpartum OCD, postpartum psychosis, and sending them and getting the treatment that they need.
Okay.
So it's already stuff that we are prepped to do,
right,
just in a slightly different population.
Well, and when I talked with Julie earlier about like postpartum care, a lot of times what happens for women is like, here's a baby, good luck, right?
Yeah, have fun.
Yeah, and so we were saying you've just had a major thing happen to your body, and now you're given a baby, which is essentially a total care patient. So you have to now take care of something.
I like that thought.
While recovering at the same time for you, and it's like, what?
Yeah.
So there's probably just even a normal mental thing of like, what?
Right. It was a total upturn of my life. No matter how much you prepare for something, no matter how much you prepare for a surgery or the birth of your child, there's always going to be things out there that are curveballs.
Yes. And I like that they came and lectured on it, on the mental side of it.
Totally.
And we were talking earlier, like, I feel like okay, so injuries in general. So I encounter this because I'm in the outpatient orthopedic side of it. There's a mental health component to almost any injury, especially like how it affects your life. Like now I have to make changes the rest of my life. Maybe I can't do this the same, or I can't do that.
Yeah.
Pelvic floor seems to accompany a lot of like shame and like feelings of inadequacies, and there's a lot of like where people maybe won't get help because they're afraid of what that emits with them.
Yes, exactly. And there's a statistic out there actually that 1 in 5 individuals who don't provide or who don't receive, I should say, the gender affirming care that they need. And that doesn't necessarily mean surgery.
Right.
That just means individuals and healthcare acknowledging and accepting and moving forward with how they view themselves. 1 in 5 individuals commit suicide.
Oh my gosh. Okay.
A huge statistic.
Right.
And it's, when you hear that, it's shocking, right? Like that's a lot of people.
Right.
For something that I believe doesn't need to happen. Because again, a pelvic floor is a pelvic floor. We can treat it in whoever.
Right.
And I don't know if you plan on having someone who does men and women's health. There are, of course, differences like gender affirming care versus a native vagina or penis. However, they have a lot of crossover because it's similar muscles.
Right.
So when I hear a statistic of 1 in 5, at least from the PT perspective, 1 in 5 committing suicide for interventions that I can easily implement, it's shocking to hear.
That if they could just find someone who was accepting or who could give these options or create a safe space, right? Yeah. And again, for me, that's a big thing, just even for physical therapy. Like, I want my patients to feel comfortable. I want them to feel like they can talk to me. I want them to feel like they have someone on their side.
Totally.
Right? Because a lot of times through these journeys, it's you're trying and you're encountering a lot of things. When I talk about fighting for your healthcare, a lot of times people, for whatever, have had to push through things just to get to a practitioner.
Yeah.
And so it makes me sad. So I am, are you okay saying what clinic you're at?
Yeah. Okay. I work at Arizona Physical Therapy. We're down in Gilbert, Arizona, right off Higley. Everyone is welcome to come.
Perfect.
Again, we are in a postpartum lens, but we treat men for their knees. We have I'm a regular orthopedic PT too, right? Like, just because you have pelvic floor doesn't mean you don't have low back pain. Right. It doesn't mean that your shoulder's starting to stiffen up, right?
Well, so a lot of times I think there's probably also like, because this isn't working, the rest of the body has got to be doing other things.
Always.
So I'm assuming you've got to be Are you ever just like, today I just want a boring knee? Or something?
Yeah.
Like, as terrible as that sounds.
Yes, come in with some knee OA.
Yeah.
Let's try needle, get some
Yeah,
stability exercises.
Perfect.
Yes.
But that is also a good point that you brought up about how with the pelvic floor, though, the rest of the body's probably been making changes that they're still worried about this, that once that starts to feel better, they're probably like, oh shit, my back, oh shit,
Always.
my hips,
Yeah.
you know, and that's why a good orthopedic background helps,
Yes.
right, for all of that.
I would say most of my patients, my pelvic floor patients, become my orthopedic patients after. It's so funny where I'm talking to patients, we're doing internal pelvic floor PT or we're just treating whatever, and they're like, oh, I dislocated my patella like a year ago, or oh, my back has been hurting for the past 10 years.
Right.
I get these really chronic headaches. I can treat that too.
Right.
Depending on insurance, of course, and like doctor referrals sometimes. But I learned it perfectly in my scope of practice. Let's do it. Let's get it all out of the way.
Well, and also it's probably, again, I always talk about like when someone's in a car accident, they're usually like, my head or this and that, and it's screaming and screaming. And then when that's gone, then they're like, oh, by the way, I have this.
Totally.
Right?
Yes.
Then you feel the things, but also if you've created a safe space where someone feels comfortable,
Yeah.
so then they're more likely to be like, oh, can you also help me with this?
Yes.
Can you also do this? Because now they feel safe with you.
Totally. Yes.
Just out of curiosity, how do you create that for someone in the first visit? Someone coming in skeptical and like, I don't know, or maybe they've been through some crappy stuff on the way.
Totally.
Like, how do you guys do that for your clinic?
Great question, because that's majority of our patients.
Okay.
I think, I'm not sure if you've talked about what internal pelvic floor PT is.
A little bit. We've also talked about how a lot of people are really nervous about that.
Totally. I think our clinic, it's never anything that we push for, but internal pelvic floor PT, which if you don't mind, can I
break it down for people?
Because it goes into people being nervous the first visit. So internal pelvic floor PT, they undress from the waist down. They're covered with a sheet completely the whole time,
right,
with gloved hands and a lubricated finger, either entering vaginally or rectally, depending on who the patient is. And that's how the pelvic floor assessment happens. We have them give us a squeeze, push or bear down for prolapse, and then physically checking, are the muscles very tense? Are they weak? What is the dysfunction happening? So when they come in, some people have an idea, maybe this will happen. Some people are like, I have no idea what you're going to do to me. And that's very intimidating.
Yes.
There's a big power dynamic between a provider and a patient. And in PT school, I actually worked with Kimberly, who was one of your guests.
Episode 1.
Yes.
Yay.
Me and her did a research project in physical therapy school that talked about why do patients not feel comfortable telling their providers information? It's because of that power dynamic. So being aware of that first visit, I try to scale down and educate as much as I can.
Right.
What we get done in the first visit is never pushed. And I try to, one, always check in with people. I like to preface things a lot. So if it's their first visit, I get their story. I let them talk for however much they want, because often patients don't get the time to tell their story. And then I ask, what do you know of pelvic floor PT? Let's open the conversation of where are you at, and do you know anything about it? Most people say, I have no idea. Some people are like, oh, I see these Instagram reels, and this is kind of what I'm aware of. I'm like, great, let's go down that path. And then we start with just education. I show them what's going to happen with a pelvis. So they're going to know completely. I go through my whole exam externally with a pelvis before we even
just get in there and be like, take your pants off. Let's do this.
Yes. And I preface, this is the direction I'm talking about for your treatment. If you hate this, we do not have to do it. There are lots of avenues we can go. And some people do, after I go through my whole spiel of this is your pelvic floor, this is what I want to do for treatment. They're like, no. And I even tell them, if it's not 100% yes, then we're not going to do it today. Let's try it the next visit. Let's try it in a couple of visits. Sit on it, talk about it. I'm always happy to answer questions. Some people are like, yes, this is my third kid. Let's get this over with. Like, you're not the first person. You're not going to be the last. I appreciate you being professional, but let's go kind of. But some patients, if I sense any hesitancy, I'm like, okay, let's do a low back screen. I'm sure your low back hurts. Like, let's go through that.
Build the trust before you just launch into that.
Yes, let's go over some breath work. Let's get you in a place where you can feel comfortable here.
Right.
It doesn't change what we're doing. I think this is going on with your pelvic floor. If I'm right, this is how I'm going to treat it.
Okay.
Let's go through some external stuff. Let's go through some breath work. Let's go through some yoga poses. So you just start to feel like, okay, this is what we're doing. Do I want to do internal? No, I'm getting along and I'm doing stuff well and I'm progressing without having to do it. I don't have to do it.
Right.
So I think creating a safe space involves high level of education, lots of patience, and always following the patient's lead and never just pushing through with your agenda of let's do this.
Right.
Even patients that I do internal with, if it's like their third or fourth visit, every time I check, are we doing internal today? What's going on?
To make sure they're comfortable.
Are we skipping? Some people are like, I'm on my menstrual cycle. I don't feel comfortable. It's like always checking in with what they're doing.
Right. Well, it's interesting that provider dynamic paper. I was like, that's very, because so much of the world, I feel like when I go, like, even if I go to my doctor or whatever, and I go in, they're like, they have 2 minutes with me, right? They run in, they like do thing, they tell me what we're going to do based off of whatever, and then they peace out.
Yeah. Totally.
And I'm like, what just happened?
Yes. And I had so many questions I blinked out on.
And I'm just sitting there like, huh? And I work in healthcare.
Yes,
right? And I'm trying to like, and I had one doctor once, he's like, well, I'm double booked all day and all this, and I'm like, don't even give me that shit.
Totally.
But I understand.
It's just my time.
Yeah. But I from a medical perspective, I get he's got to see a gazillion people. So
insurance, not to drift down your path.
We already know my lectures of how you have to survive, but how do you get that one-on-one time? Like, how do you get, like, do you get an hour with somebody?
Yeah.
Do you get, like, how does that work for you guys?
Great question. We run our clinic on a half-hour schedule and we never double book.
Perfect.
I think being in pelvic floor PT, you can't really double book.
2 people simultaneous.
We joke about it all the time. Let's get 2 beds set up.
Let's do
a group treatment session. So just by nature of it, we have to slow down. And in order to, we do take cash pay, but we're also an insurance-based clinic.
Right.
So in order to still make a profit, we figured out that the patient has an hour with us, a half hour one-on-one time with a PT, and then one-on-one time with our techs.
Okay.
And I do want to say our techs are highly trained. I mean, more so than just your average, I want to come to PT school, let me do this kind of intervention.
On the side, yeah.
They've been there for many years. Some techs have been working there longer than I've been a PT.
Oh, wow, okay.
They understand what we're doing. We've educated them. This is what we're doing in the room. These are the common things that we're seeing. And we really try to place, I don't want to say customer service, but maybe comfort for patient above all else. So we really like individual time with everyone.
Okay.
So they're there for an hour. They see me or whatever PT or PTA in the room, closed door session, and then they come out to the gym and work with the techs on what we're prescribing them.
Okay. No, and I like that because then you're not hurrying.
No.
So you actually have time to listen to your patient.
Yes.
And then you can change your session based off of that response.
Yes.
The patient's not just being like, okay, well, I've got 2 more people in 5 minutes.
Yes.
And like this and that. So
yeah.
So I appreciate that. So that's why I wanted to let people know where you were. So if they're looking for that or if they're needing that kind of thing. How are you, like, I guess on a level, like, how are you marketing? How are you getting your message out? I mean, obviously a lot of postpartum, but also how are you getting your message out for gender affirming even?
Good question. I think it's an easier thing to market towards postpartum care.
Probably so.
Because OB-GYN is a big thing, right? Midwives are a big thing. I work in Gilbert and that we kind of joke like, Gilbert's a little crunchy granola. Like people love doulas. They love midwives. They love postpartum care. Like those moms are already in
that headspace.
To get it. And my patients will tell me all the time, moms talk.
Oh.
So we do market to doctors. We have established care with certain urogynecologists, certain OB-GYNs. We have very good relationships with a lot of midwives because we think that's a really fantastic avenue for childbirth.
Right.
But
Moms groups.
moms groups are huge. They always joke, the mom Facebook groups, they will name drop people directly on who they feel comfortable with. Arizona often comes up in those talks because we are like, bring your kids in. Even if they're having a full meltdown, your baby could be crying the whole time. It doesn't matter. You are welcome here. Please come. So that avenue, very easy. We've already kind of ingrained ourselves in the postpartum care, where we get enough referrals from different providers and moms. Gender affirming care, another avenue. As far as providers, we actually have one of the best in the world gender affirming surgeons. He works over at Honor Health. I'm blanking on his name.
No, I was like, you're welcome to name drop.
Dr. Toby.
And even
I'll put it in.
If you remember, you can message and we can tag it in the thing later. Even if you remember later.
He's phenomenal. He's been doing gender affirming surgery since the 90s. So he's been in the world for a long, long time. He's a huge advocate. So just having him in Scottsdale, where Honor Health is, just having him in the metro area already attracts those individuals. So how we market is, one, we always direct people to our website. And in my bio, I directly say, I'm interested in gender affirming care. Like as a provider, I say, these are the areas I'm interested in, but let me be very vocal about what's going on. Something that we've actually struggled with as a clinic is, what do we put on our front door? As far as, do we put certain flags? Do we put certain sayings that start to attract those individuals? But something we've struggled with is, we should be unbiased. Right? So by putting those on there, are we then deterring people who don't believe that from coming to our door and not having a safe space for them as well? So because it's politically charged, it's been a little difficult for us to necessarily get word out, which isn't fair, of course, for those who need gender affirming care, but to remain unbiased in the community by accepting everyone.
Well, and it's interesting, for physical therapy, you want everyone to feel comfortable. And again, we're going into an election and there's politically charged times. And it's funny because I remember I was working in a clinic before I was kind of on my own in the last election. And I would have patients of each side, and I felt like a kindergarten cop. I'd be like, you in the corner, don't look at them, and you over there, and don't even worry about what shirt so-and-so's wearing. And, because the whole goal is that you do want to be like, each patient is treated with the same equal rights. So I understand that complication of it, but I do, whenever you remember the guy's name, fire it over, because always resources, right?
Love to. Yes, absolutely.
It is an interesting, I had one of my other guests that had mentioned that some women, because there are some clinics that are just gender affirming clinics, right, that work just specifically with that population, but that they had heard from some of their female clients that they like to go to those clinics because they actually feel like they're listened to.
Yes, absolutely.
So someone actually took the time to listen to them. And I thought that was interesting. Also a little sad that you have to, as a female, that you have to go somewhere that works with a specialized population just to get heard.
Yes, totally.
And I'm like, oh, okay. That's interesting.
I think people who operate in queer spaces, gender affirming care, different kinds of areas that are often pushed aside by the rest of society and not respected or given the time of day, those individuals tend to have like an overabundance of like, please come to me, I want you to feel safe and supported. So then you've discussed before how women aren't receiving that. So it's very attractive for them to go into that, because it's like, finally someone's going to listen to my concerns. Like, I've been telling this provider I had someone 20 years, she's had pain with intercourse, which is terrible. But she's like, finally, someone is talking to me about this. And you mentioned shame. People are nervous. But when they see different marginalized communities feeling safe here, it's very easy for them to also be like, okay, I know this is a safe space.
No, and and again, I'm not trying to beat a dead horse of like, women aren't listened to and all these things, And it's kind of interesting. And again, sometimes clinics providers operating in the time space that they're given, and you know, you got to make a quick and thing with that. But I know it if you could have an area that was researched more or explored more, what would that be? Like,
yes, so I can't take credit for this. One of my patients brought it up. She's someone who had transitioned from a man to a woman, and she had a vaginoplasty. So what that involves, I mean, there's several different ways the surgery can be done. How she did it is her peritoneum was pulled up, so it's called a peritoneal pull through. So her epithelium, or her tissue of her vaginal wall, is different than a native vaginal wall. And an area that she discussed is how current native vaginas are treated with atrophy or different kinds of skin wrinkling and just different kind of vaginal care is estrogen creams and estradiol. And being prescribed that is very, very common, especially postpartum and starting to get into menopause. Estrogen cream is great. And when she saw her OB was very vocal. This is my first time seeing someone who transitioned, which I think is also valuable. This is my first time. Let's try estrogen cream because that's what I'm used to prescribing. But she was actually digging down into the research, and she's someone who wants to go into physical therapy, which is wonderful. She was digging down into the research and found, well, because this tissue is different,
it might not respond the same.
It's not going to respond the same. And I mentioned before, individuals who have or undergo a vaginoplasty need dilators. The point of dilators is to stretch the tissue. Estrogen can help stretch and improve elasticity of the vaginal wall. Well, it doesn't necessarily do that with a peritoneal pull through. So I think an area that should be researched is what sorts of hormones and different creams and whatever should be used to help improve their tissue elasticity.
Consider the different type, basically.
And even to kind of go further into that, the lubricant that I used was actually something, it wasn't bad and it wasn't causing harm, but she had tried, I believe it wasn't coconut oil. I want to say it was canola oil. And that was really good.
Interesting.
And it improved not having as much tissue breakdown and blood. Because, you know, our skin is, again, different than vaginal wall, and the way that the peritoneal pull through, like the oil of it, actually helped. So I think having different intervention is the same, but maybe different nuances of what sorts of hormones can improve that area, what sorts of, maybe not tools, but supplements to those tools will help improve it.
Yeah, and that is definitely, I mean, because it's interesting because, so I just had a visit with my gynecologist, and he was saying, like, you know, it's interesting that people don't do the estrase cream, and I think it's growing in an area, right, like that, you know, you get a lot of urologists who don't think about that, and then they have to go, and then women go back and forth, but I didn't even think about, like, now that would be a different type of tissue, right? So it's also very interesting that your patient is doing a lot of the research, right?
Which, sorry to interrupt, but that's a huge component with this population, because they've had to, in a sense, fight for their place in healthcare. They are usually over prepared with talking with research, with talking with providers, with knowing their options. Unfortunately, with educating providers, and I myself fell into that category when we were talking about the lubricant. I didn't even think that a water-based lubricant would maybe not be appropriate. It worked fine, but it wasn't the best option. So that's something that I think every provider, if they are working in this space, should be abundantly educated, but also give your patient time to educate you. Because sometimes they know more. Oftentimes they know more. They've been looking into the sphere for so long, maybe before they even had the surgery. It's something that's been ruminated and processed and thought about. It's not this quick decision that they've like, oh, okay, all of a sudden I'm going to do this, right? So their research and education is super, super important. And you need to be able to receive that, look it up on your own time, of course, but know that what they're telling you might be different than what you know, and that's okay. You should listen to them.
You know, it's interesting you say that because I always want to, like, in my head, again, with myself, I'm like, I should know everything.
Totally.
Right?
Yes. Yes.
And if I don't know everything, I'm mad at myself.
Yes.
But also, it's the practice of medicine. And if I don't learn to be receptive, then I'm not being a good practitioner for what's out there. There's a reason there's continuing ed. And I learn from my patients every single day.
Yeah.
Like every single day I learn. I'm like, you know, whether maybe it's not always about physical therapy, but I learn something every single day from my patients. And
they're fantastic educators.
Right. And I think if you go in with that, and sometimes I'm that doctor mentality that you are the authority figure, you miss out on these education moments where maybe you're like, oh, I didn't realize that would be something better. Or, you know, I've had patients come in and be like, I saw this in a thing and I'm like, oh my gosh, that's amazing. Why are we not doing this? You know, so I think that that's an important point just for a practitioner to be receptive, because if you weren't receptive, then that patient's going to leave frustrated and have to find another practitioner. But because you're open, you're in keeping that safe space for them, where you're receptive to hearing what they have to say.
Exactly.
So that's just my weird summary. But I remember I was going off to one of my friends and I was like, I feel like I should know more, but I keep trying to learn. But like, you know.
I think there's a joke. I mean, it's something that we say that PTs, PTAs, and I guess all medical practitioners should be lifelong learners. And it kind of became a joke amongst me and my friends. Whenever we do something, we're like, yep, because we're a lifelong learner. Like, but truly, like medicine adapts. Patient preferences adapt, change with the time. Again, to relate it back to Gilbert, some people don't want to have to go through a traditional hospital birth. That's a huge growing field currently. So then, okay, well, we talk about while they're currently pregnant, different positions that they can do and different kinds of things like that. That's adapting. That's something that we're learning, and that's a sphere that everyone should be educated on, but some people do want the hospital birth, and that's okay too. So always learning who your patient is, what they want to do, and more about it. Important, but then to not beat ourselves up when we don't know certain things, because we cannot know everything. But there's so much out there, and there's so much power of being like, I don't know that, but I will learn that for you. That patients really respond to and respect, rather than a provider trying to BS the situation of, oh yeah, totally, like, of course, we won't do that because this is best. And just kind of steamrolling.
We were taught that it's better to admit, like, you know, I don't know that, but I'm going to look into it for you. Let me get back to you. Versus just making something up and then later being wrong, or, you know, like,
causing harm.
Or at least being able to say, like, here's my educated guess, but I need to like look into it more.
Of course.
You know, based off of whatever. So
building that bridge.
And I think especially in these areas where it's growing, that it is, you know, because I have had patients that, again, they've lived in their body, right? So
they know it better than us.
So you tell me what works for you, because again, what works for this person's not going to work for the other person, even with the exact same diagnosis.
Truly. Yes. Agreed.
So I guess any piece of advice that you would give, like a patient maybe going for like trying to find a gender affirming practitioner, or just experiencing issues, or just even patients in general experiencing pelvic floor issues.
I think general advice, find communities that you feel comfortable in and talk to people in those communities. I think there's a lot of power, again, like moms talk, people who are in gender affirming care are in certain spaces. To refer it back to that research that Kimberly and I did when we were looking at, do providers have a power dynamic versus patients? One of the areas we looked at were Reddit threads and how patients talk to their providers a certain way versus where they come back to the Reddit threads and what they're like really feeling and their actual experience with stuff. So I think advice of course, find a provider you feel comfortable with, but maybe look inside your community with who they're seeing and who they're talking to, because there's such power in that. And if you don't feel like you have access to that, calling clinics, although it's annoying, it's kind of an easy, like, let me just get a pulse on what they think. Look things up. Different providers should have areas of interest that they have on their website. Unfortunately, is a little more front loaded to the patient. But I would rather them look and find spaces that they feel comfortable with, because there are a lot out there, as you probably are starting to explore, but make sure that you are in spheres and areas that you can talk to a community as well as find good providers.
And all that goes with kind of my message. I'm always saying, like, fight for your healthcare. So it sucks as a patient. You can't just be like, I have this problem and someone directs you, right?
Yes.
Unfortunately, but also fortunately, you have to take ownership.
Yeah.
Because if you've got this issue, take ownership and fight for what's important. Yeah. And I appreciate that. So almost interviewing the clinic. I always tell patients, you're interviewing me as much as I'm interviewing you.
Make sure you feel comfortable with who you're seeing, because if you don't, that's a huge hiccup in your healthcare.
Yes, and then it's not going to work.
Yeah.
Because you're just going to be kind of an odds, or you're not going to feel comfortable sharing probably vital information with your practitioner.
Yes, exactly.
So, I think that might be all of my annoying questions. You shared so many things, which is great. And I appreciate you kind of breaking down also some, I feel like we've skirted a little bit around like what happens in these internal exams.
Yeah. Let's lay it out.
Yeah. Because there is a little internal exam and we kind of skirted into it. So I'm excited that we're deep diving because.
And if you hate it, we don't ever have to do it.
Right.
If you don't want to do it, let's do something else that you're comfortable with. Right. Like they're muscles.
Education is probably the thing though, because I think people hear internal exam and then they're like, what does that mean? Totally. And then there's that panic and things like that. And I appreciate, like, again, pelvic floor isn't my area of expertise, but I appreciate you guys because also we were talking about when you released that, I've had some patients that see pelvic floor, but then they see me and then I'm able to do more of my things from like that perspective, or it's released out some traumas that now I can get other things to move.
Yes, exactly. If someone comes in with pelvic floor, I even have a couple patients who are like, this is my knee PT and you're my pelvic floor PT. I'm like, great, they're connected. Pelvic floor is good. Go keep seeing your knee PT and get them settled. So it's a great avenue to work together to heal the whole body.
Right. So thank you again, Sarah, for coming out and exploring, and we'll put some resources on there for you and with the surgeon and also with like your clinic and all that fun stuff. So go see her and have a good rest of the day.
Thank you for having me.
Thank you for tuning in for today's episode. As always, we hope that you found some nugget of information with all of the stories that these guests have to share. And always feel free to follow Better Fit Therapy online and on all of the social medias, Facebooks and Instagrams and all the fun things. Feel free to message at any point as well if you have a condition or you have a topic that you would like to explore. Feel free to send that in. Also, if you would like access to any of the resources or things from a different episode, please always feel free to send in a message and we can direct you. And again, thank you for taking the time, and don't forget to fight for your healthcare.